on to the next session.
Now I invite Ms. Susmi Hameed. She is an optometrist from Girida Eye Hospital with keen interest in PSV.
An optometrist and in charge of PSV at Girida Eye Hospital. So today I'm going to speak about refraction in complex case. So the first topic is pediatric refraction. Pediatric itself is a complication, right? So what are the things we have to consider before starting the pediatric refraction? First of all, we should create a rapport with the child. You know, most of the children will not get along with the strangers, especially in the hospital environment. So make sure that they are comfortable with us. That's very important thing. And also we should record all the histories from the parents that include the ocular complaints, general health history, birth history, development history, and is there any history of seizures? That's very important. And we should record all this from the parents. And the examiner should be aware of all the possible factors at different age group and also about the metropization, and should know a good skill at retinoscopy. That's very important. So here the table shows the possible refractive errors at different age group. The first age group is less than 1 year. So a healthy neonate will be hyperopic, but in some cases, if the baby born preterm and not gone for any ROP laser, the refraction will be myopic. But from 3 to 5 years, we can see all type of refractive errors. But in adolescents, most of them will be ametropic and more myopes than the hyperopic. And astigmatism and isometria will be more common in all age groups. So what is ametropization? What is the importance of ametropization? Ametropization is a process in which the refractive error of the child going to reduce or the eye become ametropic. And during the first age of the life, the metropization will be faster and gradually slow down and stop at the age of 4th year. And in adulthood, there will be more chance for myopic refraction. So what will happen if we fully correct a child during the metropization? That will interfere the normal visual functioning of the baby or the development of the visual function of the baby. And also moving further, there is a chance to develop more more refractive error in that child. So we don't have to fully correct a baby during the ametropization. That's very important. So this table will give you an idea to how to correct different refractive errors at different age groups. The first age group is less than 1 year. So if here the baby has greater than 5 diopter of hypermetropia, we can undercorrect it up to 2 diopters for the ametropization. But in the case of myopia, we can undercorrect up to 1.5 diopter, but astigmatism is not sensitive at this age because it will rapidly reduce during the ametropization. So it's not sensitive. And if the age is greater than 1 year, if the child has greater than 3.5 diopter of hypermetropia, we can undercorrect up to 1 diopter. And in myopia also, if it's greater than 2 diopters, we can undercorrect up to 1 to 1.5 diopter of myopia. And in astigmatism also, we can undercorrect up to 1 diopters if it's more than 2.5 diopter. At the 4th year of the age, if it's the hypermetropia is greater than 2.5 diopter, we can give the full correction or can slightly reduce it up to 0.5 diopter. That will depend upon the visual acuity. You know, it's 4 year, so we can that will depend on the visual acuity and symptom of the patient. And if the myopia is greater than 1 diopter, we can give a full correction or either a slight reduction. And in astigmatism, if it's greater than 1.5 diopter, we can either give the full correction or a slight initial reduction. That will depend on the visual acuity and symptom of the baby. And on the school-going ages, if it's the hypermetropia is greater than 1.5 diopter, we should correct it according to the symptom of the child. And in myopia also, we can either give the full correction or a slight reduction. That will depend upon the symptoms and visual acuity of the child. Next, astigmatism also, we can correct it or initially reduce it depending on the visual acuity and symptom of the child. So what are the challenges we will face during a pediatric refraction? Of course, the child will have a wide range of accommodation, and also they will not be cooperative enough and do not fix it properly. So there will be difficulty in quantifying visual status of the baby. So here the commonly using charts which include the Cardiff acuity, Teller's acuity, Allen's pictures, and Lea symbols. I think it's more commonly using, and OKD in infants. these are charts which is using in preschool children. So, as Sir said, cycloplegic refraction is very important. Especially in children, we have to suggest cycloplegic refraction in all children, especially those who have hypermetropia or convergent squint. Because a good amount of hypermetropia will be hidden under control of the ciliary muscle tone. So we have to suggest a cycloplegic refraction in every child, those who have hypermetropia and esotropia. In esotropia, here also the refractive or accommodative component will be we will get after the cycloplegic refraction in this condition. So, in whatever the refraction, it's cycloplegic refraction or objective refraction, try to use user-friendly things like lens tracks. In children, we can use the lens tracks because it will be user-friendly both for the examiner and also for the child. Because most of the children will not cooperate to wear the trial frame. So they should use user-friendly things while examining the child. So how to give the correction in a myopic child? We can give the full correction in a child. It's not always to under-correct the myopia, but we can correct the myopia fully. That will depend upon the visual acuity and how much the myopia, how much power required to improve the visual acuity of the patient. Because it's very important the case of the patient has amblyopia. We have to give the full correction with a tonus reduction in these cases. And we also verify that whether it's over-corrected or not. So we can do the duochrome test. It's very must in myopia. And so what will happen if we over-correct a myopia? When we over-correct a myopia and the patient is prolongedly using the myopic correction, moving further, it will stimulate the accommodative convergence of the patient. So after few months or few years, there is a chance to develop esotropia or intermittent esotropia or esophoria in that patient. So the patient will be very symptomatic, especially the children. They have very accommodative ability. So if we overcorrect the myopia, that will again stimulate the accommodation of the patient, hence the accommodative convergence. That will that will make ESO deviation or convergence squint further in their development stages. So in these conditions, we have to undercorrect the myopia of the patients. Or if the myopia is not much corrected, but the patients still have these kind of symptoms, we have to go for the bifocals in those children. So next is refraction in hypermetropia. We don't have to fully correct a hypermetropic child if there is no convergent squint. And we should record all the accommodative amplitude, especially if in a routine checkup the patient child is or any patient is hypermetropic, we should consider to perform an NPC, a simple NPC or NPA. That's very simple. So we should do the accumulative, we should measure the accumulative amplitude in every patient, those who have hypermetropia. And we should perform the fogging. It's very important. I'm not going to explain detail. And refraction in astigmatism. We can correct the astigmatism in every children, those who are greater than 4 years, and they are very symptomatic. And also we should correct the oblique astigmatism fully, because oblique astigmatism is more prone to develop amblyopia. So in this case of oblique astigmatism, we have to correct the full amount of astigmatism. And we should record the keratometry value. If the patient has greater than 3 diopter of keratometry or astigmatism, we have to record the keratometry in order to confirm whether it's corneal or not. So next is refraction in strabismus. Most of the refractive course of the strabismus will be a high myopia, hypermetropic or myopic astigmatism. So cycloplegic refraction is very important in these cases, especially in strabismus and hyperopic patients. So suppose the patient is myopic and the child has an intermittent exotropia or a large angle exotropia, we can give the full correction. We can give the full cycloplegic correction or either a slight overcorrection. If it's improving the PSV of the patient, it's okay to slightly overcorrect the myopia of the patient. So Next is a refraction in refractive accommodative esotropia. Refractive accommodative esotropia is a condition here which happens due to the over accommodation with the patients who have high amount of hypermetropia. So here also fogging, in subjective refraction, fogging is very important, and also should advise a cycloplegia in every patient, those who have hypermetropia and accommodative esotropia. So here in some cases the patient will complain, the child will complain diplopia at a distance if its esotropia is more at the distance. And here also there is a chance to develop, here in these cases it is actually occurring due to the over accommodation of the patient. So the near esotropia will be higher when comparing to the distance esotropia. So here the AC barrier should be higher. So due to this problem, we have to fog, we have to give the full cycloplegic correction for this child. And also if it's not controlling the, it's not reducing the AC barrier ratio of the patient, we have to go for the bifocals in these children. And next important condition is accommodative spasm. This is very common since the pandemic. It's actually occurring due to the prolonged near work, and it's happening in accommodatively active patients. So sometimes it may stimulate conditions the patient has using the pilocarpine. So here their accommodation will be arrested at the near. It is happening due to the prolonged use of near work. So their accommodation will be arrested at near for a long time. So here the patient's first complaint will be blurring at the distance, and also associated headaches, eye strains, and difficulty while concentrating. So here we can see the possible PSV findings here. That is, there's a chance for occasional esotropia or esophoria in some patients, and while it's better to advise an orthoptic evaluation in such patients. If we do the orthoptic evaluation, we can find the reduced AF value. That would be a difficulty in clearing the plus lens, and also the reduced negative relative accommodation is very important, and difficulty with the plus lenses. Normal NPC and NPA value will be normal here cases. And while refracting the patients, when we take the order of value, we will get a high myopic value. But while we are doing the retinoscopy, we will also get a high myopia to hyperopic value. So here cycloplegic refraction is very important. Whether the patient is 30 plus or a child, we have to suggest a cycloplegic refraction in this kind of patients. Well, during the subjective refraction, if we check the unaided visual acuity of the patient, that would be fluctuating from the counting fingers to 6-9 or 6-12. That will be depending on the severity of the condition. And also the near visual acuity also will be varying, because the patient couldn't concentrate more at the near due to the excessive stimulation of the accommodative convergence. So the patient also, actually they will have a good near visual acuity, but it will be varying due to the hour strain. And here also the patient will eat up more minus while refracting the patients. And there also we can see an improvement in their visual acuity also. But post-titration, if we try to check the unaided visual acuity of the patient, we can see a definite improvement in their visual acuity. So how to manage this kind of patients? In a rare conditions, there is a chance to resolve the spasm at a first cycloplegia, but most of the cases will take time to resolve. So that's such conditions we have to give a cycloplegia along with the near ad. So first we can try hometropine. If it's not requiring, it's not improving the condition, we have to go for an atropine with a addition. So next important condition is subluxated lens. So subluxated lens is a condition. Here the lens will be partially displaced from the pupillary area. That would be varying. It may sometimes displaced from a large portions, or it may be partially. So here these conditions, we will get two type of refraction. One myopia, a high myopic refraction, and also a phakic refraction, that is a high plus refraction. So here the patient will complain of defective vision and also monocular diplopia due to these two kind of refraction. So here the refraction will be lenticular. We will get a high myopia or a high astigmatism usually the lenticular. So how to manage this patient? We have to do both the phakic and refractive, phakic and aphakic refraction here. And subjective undilated refraction is very important in this case, because after the dilatation, the aphakic area will be more exposed. So the patient will not satisfied while correcting this aphakic correction. Why we give the aphakic correction. So we have to do a perfect phakic refraction, that is undilated refraction. Then we should correct the myopia properly in these cases. So early we used to correct the aphakic correction along with the atropine, but now we usually go for a surgery. So thank you.